Welcome to the presentation of our paper, Continuous Real-Time Remote Monitoring of Severely or Chronically Ill Children. My name is Claudia Pedron. I am of the University of Applied Science of Eastern Switzerland in St. Gallen. On behalf of my co-authors, I am happy to introduce you to our project. Before I start my presentation, I want to tell you something about my person. I am a civil engineer. I got my diploma at the University of Trient in Italy and a PhD at the Swiss Federal Institute of Technology in Zurich in the area of e-learning for civil engineering students. Since 2012, I am a lecturer at the Swiss Universities of Applied Science. The focus of my teaching is on process management and process automation. My current research activities comprehend the conception and development of tools for sustainable urban planning, as well as the conception and development of process management and rule systems. A further research field of mine is the low-code programming. Digital business, digital health, and digital society are the topics of research interest of my group. Imagine now the little Emma, 4 years old. Emma suffers from a severe form of epileptic seizures since birth. During seizures, she loses consciousness, suffers from convulsive jerks, and often the breathing stops. The little girl could be in danger of suffocating. The first 2 years of their life, Emma spent most of the time in the clinic, which meant great stress for her and her family. Then the mother decides to take Emma home because she thinks that she could cope with the risks and knows how to handle them. Indeed, the doctor has instructed her what measures to take in case of a seizure. Most nights, however, are restless for the mother. She hardly sleeps because she is constantly worried that she might miss any sign of possible exacerbation. After some weeks, she's exhausted. One solution for Emma would be to go back to the clinic. Another could be our solution. Seriously ill children and children with a severe disability need continuous monitoring, whether they are in a hospital or at home. This often comes with high costs for health authorities, insurers, or for the parents. In most cases, it is the mother who takes responsibility for caring the sick child. Sometimes she might get the support of nursing services, for example, in form of night watches. Such a service is also offered by the ambulatory care service in Eastern Switzerland, which initiated our project. Night watches, however, are costly and require a great deal of resources, which, given the shortage of well-qualified nurses, has become a major challenge. The aim of the project was to develop comprehensive services for real-time remote medical monitoring of critically ill children to relieve the burden on caregivers, usually the parents, during the night hours. This was achieved by having professional nurses who monitor critical vital parameters at night. The main objects we derived were to develop a remote monitoring system for severely ill children, not inferior to stationary monitoring in a hospital, to reduce the physical and psychological strain of parents taking care of their children, to prevent chronic stress and possible burnout, especially for the parents, to increase the safety of the patients and to fulfill the conditions to succeed in the first healthcare market, for example, to have the service reimbursed. The project was funded by the National Commission for Technology and Innovation, CTI, and ran for 4 years, from 2016 to 2019. The partners of the project were the Kinderspitäx Horn, our application partner, which uses the solution to improve the quality of life of its patients and their caregivers. The Thurgau Hospital in Münsterlingen, which was our medical partner responsible for defining the relevant vital parameters and various test setups. The software company Xmind, which was the implementation partner, the company Net Monitoring, which will offer the infrastructure once the solution can be implemented in an organization, the University of Applied Science in St. Gallen, in the meanwhile, the University of Applied Science of Eastern Switzerland, which was responsible for the project management and research and development in remote monitoring, thanks to the track record in digital health which it has. The overall goal it is developing a prototype for the continuous real-time remote monitoring by means of transmitting vital data could be broken down into the following research questions. 1. Can a remote monitoring solution be established that is comparable to stationary monitoring in terms of reliability and accuracy? 2. Which are the relevant processes and how must these processes be designed? 3. How should professional nursing staff intervene to best support the relatives in case of an alarm? 4. Which are the prerequisites to introduce the remote monitoring system into the first healthcare market? A comprehensive literature review shows that there are many remote monitoring solutions, usually based on wearables, ambient system, or cameras. Those solutions target chronic diseases such as diabetes, cardiovascular and respiratory systems, fall detection, mobility-related diseases, and more. However, only few solutions target children who tend to have special requirements, for example, with regard to the size of the sensors or how these can be attached to the body. One of them is a smart monitoring solution based on wearable sensors and smartphone, which continuously monitors a child's activity and vital signs. Another one is based on wearable vest, which monitors chronically ill children and keeps parents informed about the child's health status. The main gap we encountered was that most studies failed to discuss how to embed the remote monitoring system into organizational processes. In this slide, you can see the application scenario of our solution. The home solution is composed of the following components: the medical devices and sensors, the data transfer architecture, an on-demand audio and video surveillance system in the child's bedroom, here, 2 phones in the master bedroom, here, the monitoring center based at the headquarters of the Ambulatory Care Association, here. For the purpose of monitoring, sensors are attached to the body of the child, and the values or the vital parameters are continuously transmitted to a monitoring center, if you can see here. This monitoring center is based at the headquarters of the Ambulatory Care Association for the children, where experienced nurses watch the data streams on a dashboard, here. Nursing staff monitor patients in real time for up to 12 hours during the night. Comparable to a traffic light system, the color red indicates danger or emergency. You can see this here. Yellow stands for caution and green means go. If vital signs exceed or fall below the thresholds set by a doctor, the color turns yellow or red. In the case of a red alarm, the nurse can wake the patient, the parents, and, if necessary, instruct them through the appropriate measures by phone, if you can see here. In severe cases, the professional staff in the monitoring center might contact the ambulance straight away. To prevent false alarms, a video surveillance system enables the nurses to observe the child and judge, for example, if an epileptic seizure is imminent. You can see here the video surveillance system. The choice of vital parameters was largely determined by the physician involved in the project and the parameters usually monitored in the hospital, for example respiration rate, heart rate, and oxygen saturation. These parameters tend to be relevant for most diseases. Besides, they quickly respond to changes in a patient's condition, within seconds in the case of heart rate and within minutes as far as oxygen saturation is concerned, and are therefore particularly suited for monitoring purposes. Heart rate is the most relevant parameter and acquired by a medical-approved electrocardiogram device. Respiration rate proved to be the most challenging parameter. The values measured showed some deviations compared with the manual counting performed on the two systems we tested. One was derived from the electrocardiogram by impedance tomography. The other was acquired from audio signals from a microphone placed on the throat. Besides, we found artifacts in all measurements, which is why we decided to use this parameter just in combination with other parameters to reduce the rate of false alarms. For measuring oxygen saturation, we used a pulse oximeter. We use a small clamp-like device which is placed on a finger or two. Since there is a danger that the device might fall off during the night, especially from a small child's finger, we choose one that could be attached via adhesive tape instead of a clamp. A major task consisted in defining the processes for the implementation of a monitoring system in the context of the organization, especially the interaction processes between nurses, caregivers at home, and emergency staff. For example, to decide if an alert had to be issued and to identify the relevant person to alert in case there was an emergency. Another important process was the alerting of the parents, for example, to make sure that it was really an urgent matter, which we could verify with the audio-visual surveillance. Other important processes included the shifting of responsibilities from the nurses to the parents and back after an emergency had been solved by the assisting of the nurse via telephone. What were the main challenges in the project? We had to prove and demonstrate that our system was not inferior to a stationary monitoring in a hospital. A major prerequisite in this context coming from the physician in the project was that we had to use medically approved devices. We also had to find the right balance between safety or caution on the one hand and running the risk of missing an emergency on the other hand. In a hospital, false alarms are not a problem since the nurse is just a few steps away from the patient. In our setting, a false alarm means waking the mother and is therefore more disruptive. We had to find medically approved monitors which let us access the raw data in real time. This wasn't an easy task since most monitors either had no possibility for externally accessing data at all or they just provided proprietary and undocumented interfaces. To reduce the number of alarms due to the false positives, we constantly improved our algorithms. And we also had to cope with a vulnerable target group of children, which have special requirements regarding acceptance and usability for the system, for example, unobtrusive sensors. In this slide, you can see the setup in the monitoring center, which consists of a center dashboard and 3 individual surveillance stations. The dashboard provides an overview of all the patients that are being monitored. It includes their names, the most recent values of each vital parameter, and the status color, green, yellow, or red. A patient status color can only be downgraded from red to yellow or to green if the patient has been inspected on one of the surveillance stations to make sure that any potential critical situation has been resolved. For the monitoring unit, we define different quantitative parameters. Depending on the case mix and the expected number of alarms, up to 20 patients can be monitored simultaneously. A child can be monitored for a maximum of 12 hours, and the service is offered from 8 p.m. to 8 a.m. with 2 active nurses and 1 nurse on standby. At the individual surveillance workstations, nurses get a list of all children ordered by their status, which with the most critical cases listed on top. The second criterion for sorting is the time span since the last inspection, which makes sure that every child undergoes an inspection from time to time and patients have not already been inspected by someone else recently. A nurse can view a patient in detail using the patient window, which you can see on the right side. In the patient window, each vital parameter is displayed in a separate chart, and the nurse can select a specific period to view. The nurse can also monitor a child via video, and in the case of real emergency, initiate a phone call with the parents by just pressing a button. All inspections are logged by the system. At the beginning of our tests, we observed an unexpectedly high number of alarms due to many false positives. We could reduce the number of false positives by iteratively adjusting and improving the algorithm and by introducing the video surveillance system as is a necessity before calling the parents. The table shows an example of monitoring 3 patients and the results for specific alarms. Some of them were triggered due to the missing data or lost sensors, which could be easily identified with the audio-visual inspection. Possible problems for respiration rates strongly depend on the individual patient. For example, if a child moves a lot during the night. The table also shows the ratio between justified and unjustified alarms. No alarms have been neglected, however, which is one crucial criterion for the system. Our evaluation included the measurement of the acceptance of the monitoring system. A prototype was implemented in a home for up to 8 severely ill children, which is supervised by the Ambulatory Care Association for Children. We asked 21 nurses to rate the potential benefits of the system. According to the user's experience, all parents supported by them suffer from poor sleep. The nurses expect that in 75% of cases with night watches, these night watches could be replaced by a remote monitoring system. In about half of the cases without night watches, which are the less severe case usually, nurses expect that sleep problems could be reduced in over 90% of cases. The project has a strong focus on user needs and therefore pursued a participatory development approach. Iterative testing with nursing staff in the monitoring center and continuous integration of their feedback has led to a high overall user friendliness of the monitoring application as well as easy-to-use graphical user interfaces. In this slide, you can see the difference between early and later version of the patient overview section. The information given about each patient has been considerably reduced to focus on the essential. To succeed in the first healthcare market, it is mandatory that the insurance companies reimburse the service provided by remote monitoring system. In order to achieve this, it is necessary that the remote monitoring system gets approved by the Swiss Agency for Therapeutic Products, Swissmedic. Therefore, evidence must be furnished to prove the usefulness, cost-effectiveness, and efficiency of the solution. Usefulness implies both preventive and therapeutic purposes. On the one hand, the preventive purpose consists of the early detection of exacerbations of the child's states of health, as well as of the enablement of early intervention to minimize the risk of dangerous situations. On the other hand, the aim is to provide more restful nights for the parents and reduce their stress. The therapeutic purpose consists of contributing to a child's recovery as well as to enhancing the patient's quality of life. Cost effectiveness. As already mentioned, approval of the remote monitoring system by the Swiss Ministry of Social Insurance is a prerequisite for introducing the service into regular healthcare delivery. Only medical services with a tariff number can be invoiced. Currently, no such number exists for monitoring services. As a result of the corona crisis, chances are good that this might happen in the near future. Efficiency. The remote monitoring system has contributed to an increase of productivity thanks to the simultaneous monitoring of up to 20 patients by 3 nurses in the central monitoring unit instead of 1 nurse per child provided by one-side night watches. The full inclusive fee for the remote monitoring service turns out to be about 5 times cheaper than on one-side night watch performed by a nurse. A more efficient use of nursing staff, which is in short supply, a reduction of the costs incurred as a result of the chronic stress suffered by caring parents, and the possible loss of income from paid work. Conclusions. We can conclude that continuous remote monitoring is feasible and, if implemented properly, is equivalent or not inferior to monitoring in a hospital environment. One major challenge was to reduce the high number of alarms per child, which we observed at the beginning of our tests. This was also a reason why the audiovisual inspection in the case of an emergency turned out to be a central element in remote monitoring, something that was not included in the original study design. Another important aspect was to embed the system into the process landscape of the monitoring organization, which was essential for its acceptance. One of the main goals, that means to reduce the burden on the parents, was achieved according to the nurses involved in the project. Negotiations with the Swiss Ministry of Social Insurance are ongoing, with the aim that the service provided by the remote monitoring system should be paid by the insurance companies. Because of the corona crisis, there appears to be more openness toward remote services, so chances are good.